Dr. Leroux.
Sorry, I know that Ms. Clark has put an apology. I'm not sure why the committee chair hasn't received it yet, but she has put in an apology for tonight. Unfortunately, she couldn't make it.
Okay, thank you very much. Okay, thank you, honorable members, for really agreeing to really adjust and come 30 minutes earlier. Minister, we would like to indicate to you that we have had meetings over this week. Started on Tuesday, listening to Financial and Fiscal Commission, Auditor General, South African Medical Research Council, and we ended up with Mines and Works Compensation Fund. The next day, Wednesday, we listened to Council for Medical Schemes, SAPRA, Office of the Health Ombuds, and Office of the Health Standard Compliance. Then members would probably ask some of the things that have come up from those presentations together with the presentation that we are going to be making now. We would therefore want to just remind the minister that this report was sent to us yesterday, so we are familiar with it, and we would not say, please take us through word for word on the 64 slides. In fact, scanning through the report, I would be happy if those you will delegate starts on slide number 8. We have had a meeting with the minister and his team about 2 months ago, where we were, all of us as new members, trying to understand what is this department all about, what are they doing and all that. But the gist of your report starts mainly on slide number 8. But let me leave that to you for now to start, and we will come at the end of your presentation for the questions. We would allocate you about 40 minutes, probably another 5 minutes more. We hope we will be able to do some adjustments from your 64 slides. Thank you very much. Over to you, Minister.
Thank you very much, Chairperson, and thank you, honorable members. As the honorable members have already been sort of introduced by calling their names, can I also give this opportunity to the Director General, Dr. Sandile Buthelezi, to introduce members of his team to the members of the honorable members of the Portfolio Committee. Dr. Buthelezi, please.
Thank you very much, Minister, and thank you very much to the Honorable Chair, honorable members. We are led by the Minister and the Deputy Minister, and I am on the administration. I'm accompanied by a number of DDGs, DDG Professor Chris for National Health Insurance, DDG Paswa Mamokhale, who is a CFO, DDG Jeanette Hunter, who's responsible for primary health care. I'm sure we will be joined by Dr. Mahlati, who's responsible for hospital services and also corporate services, and supported Dr. Anban Pillay is out of the country, one of the other DDGs. And then the team that will lead with the presentation, Honorable Minister, will be our Chief Director responsible for M&E in the department, Ms. Zondi, and then supported by the CFO on the financials. We do have our parliamentary support staff with us as well, and also guys from legal services. Thank you very much, Honorable Minister.
Thank you. Thank you very much, DG. Chairperson and honorable members, thank you for this opportunity. But I must state up front that I think myself and the Deputy Minister, we have got a plane to catch at 8:30 this evening, because there's a special cabinet, urgent special cabinet, which the President has called in Pretoria. As you know, we're all in Cape Town. So I'm just appealing that we do have such limitations of time, but we are happy that we started 30 minutes earlier than was indicated. Now, without any waste of time, I'll give over.
Excuse me, Minister.
Yes.
Yeah, this program, this meeting is screened live from our parliamentary TV. So we'll request you and those who will be presenting, including when we ask questions ourselves, to show our videos, please. Thank you.
Okay, I'm sure I'll show it for the duration when I'm speaking. So, but without any waste of time, as you have already said, Chairperson, let's support your approach to this meeting that we have gone through this report. I'll give it over to the DG to start the presentation already, and then will participate in the answering of questions. DG, please take over.
Thank you very much, Honorable Minister. Ms. Zondi, are you able to beam the presentation and start from slide 8 as requested by the chair, please? Thank you.
Yes, DG, thank you and good afternoon to the chairperson, the members of the portfolio committee, the minister and the deputy minister. I'm going to share. Share the screen. Share final. DG, is my presentation visible?
No, no, please open it. We can just see the files.
Stop the sharing. Shade. Okay, let's share again. Is it visible now, DG?
Yes, thank you.
Thank you. Just sort of something. Okay, so I will, as per the chairperson's guidance, I'll go to slide 8 on performance information, which is the first part of the presentation. So starting with, oops, I think it's just the wrong presentation, this one that I've screened. Let me apologize for that. Final. There it is. Okay, so slide 8. Okay, slide 8 starts with the target of the unqualified audit opinion, which we have achieved. The 30-day payment, of which we were able to pay 90% of our invoices within 30 days, and we missed about 10% of them due to the support that we had to provide to the provinces in relation to the medical legal claims. And then that made up about 73% of the late payments, and the remainder we had to address the issues within the NDOH. And then the next one talks to the draft bill to manage medical legal claims, which was developed but not finalized due to the process that needed to unfold that involves the Minister of Justice. The next one was to be able to pilot the case management system in 4 provinces. We had a challenge of the contract expiring, and subsequently we were able to source the funding from Global Fund for the data capturers that will capture the historical data in the provinces. We have exceeded the target on 100 health promotion messages that had to be put on social media. And in terms of the unannounced visits, we had we had a target of 8. However, we had 6 unannounced visits done by the minister and the deputy minister to observe service delivery. We have exceeded the target on the health and business with the communities. It was a busy election year. Then coming to our equity targets, we had a target of 50% for the women at SMS level, and we achieved 45% owing to retirement, death, and resignations. We also had a target of 30% of youth employed in NDOH, and we achieved 5%, 7% for disabilities, and we achieved 0.1%. The target here was set very high. However, we've since consulted the Department of Women, Children, Youth, and People with Disabilities to actually make sure that we bring it closer to the norm. So in terms of addressing the challenges, we have our branch heads that had to put procedures in place. The work is ongoing with the Department of Justice for the legal claims, and we intend to ensure that we fill the posts within 3 months before the exit of the existing official, and also appointment of interns and targeted recruitment strategies, including putting our advertisements on social media. Coming to this program 2, National Health Insurance, here we had 2 targets. First one being on the model for contracting developed and documented, and also identified concepts that are tested in 9 CAPs. We achieved the part where we were able to have the contracting model developed. However, we were not able to test in the 9 contracting units for primary health care due to the changes that happened in the during the discussion on the NHI bill, which then meant that that component gets delayed. However, it has been picked up in the current financial year. For the Central Chronic Medication Dispensing and Distribution Program, we had a target of 5 million, and we have exceeded that. We reached more than 9 million. So I've addressed this one. Coming to program 3 on communicable and non-communicable diseases, we had the first target on 340 facilities offering HIV self-screening that we have exceeded as we achieved 839. We also exceeded just by 1 the number of facilities with youth zones. We are having challenges with TB treatment, where we had a target of 90% and we achieved 71%. That was for the drug-susceptible TB. And then for the multi-drug resistant TB, we had a target of 78 and we achieved 60.7%. And really the reasons have to do with the patients that had unknown HIV status while on TB treatment, that also tended to be tended to have poor treatment outcomes, but also the issues of support to the patients that are on treatment. We had a target of 223,654 for people started on TB treatment. We missed this target by 43,233 because the patients that were confirmed for TB ended up not being started on treatment due to various factors such as transport, social, behavioral issues, lack of income, and food. In terms of the target for introducing HPV screening for cervical cancer in the districts, we had a target of 4. However, there were delays for this as the department needed to develop the algorithm after the approval of the strategy. So this one is being picked up in the current financial year. We also had a target regarding the training of clinicians that would be certified competent in any of the 14 SRH modules that we far exceeded due to increased uptake of the online training. In terms of the districts with non-acute flaccid paralysis detection rate of less than equals to 4 per 100,000 amongst children less than 15 years, we had a target of 42 districts, and we reached 8. We had challenges with regards to capacity here, including the shortage of surveillance officers at the district level, as well as the travel restrictions that were put in place as we experienced the in-year budget cuts for the financial year. In terms of the targets of 5 schistosomiasis endemic districts administering Praziquantel for school attending children, we exceeded this target by 1 district. For malaria, we had a target of 2 sub-districts implementing the foster clearing program, which we have achieved. We also have achieved our screening targets for both hypertension and diabetes. In fact, we have exceeded these. We had 4 national NCD campaigns as planned. And then for the target on the position paper restricting advertising of unhealthy food during children TV times and on other children's platform developed, we've done that. For the patients admitted into designated psychiatric hospitals, we had a target of 200 and we exceeded it by 138. We also had the draft national plan to strengthen the public health system capacity to cater for mental health needs of children and adolescents developed as planned. We just exceeded by 1 the number of hospitals that obtain 75% and above on food service policy assessment tool. So we are putting in place measures to deal with TB treatment success rate, and that includes the mortality audits, the tracing and retention of patients, and also the implementation of the TB recovery plan, as well as the closer collaboration with the community health worker program. And we are engaging in the deep dives to ensure that we can actually engage the districts and the provinces in improving the number of patients that are diagnosed that get started on treatment. We have a national surveillance manager that was deployed by WHO to support us with polio interventions. And then we have commenced in this financial year with the HPV screening for cervical cancer in the districts. Coming to Program 4 on primary health care, the district health system policy framework and strategy for 24 to 29 was developed but was not finalized due to extended consultations. In terms of the district health management office guidelines, we had planned to develop this. However, it proved that these guidelines are actually linked to the NHI contracting units for primary health care. So which then got delayed. So we are then reworking this out. In terms of the community outreach services to household, we had a target of 20.5 million and we reached 19.5 million due to the reduced number of community health workers that could not be replaced due to the budget cuts. Then for the clinic committees for primary health care, we have exceeded this target due to good leadership from the MECs that supported the program. For the ports of entry compliance with international health regulations, we achieved our target of 30. Same with the metros and the districts that were compliant with the national environmental health norms and standards. We achieved our target of 26. We also achieved the compliance with the regulation relating to standards for emergency medical services in all the provinces. So I've already addressed some of the interventions here. I will move straight to program 5. So for the hospital services, we had a hospital strategy concept document finalized for NHC approval. It was developed, however, it has not yet been approved due to extended consultations that were required. In terms of our infrastructure program, we have reached our target of 45 PHC facilities constructed or revitalized. Same with hospitals constructed or revitalized, target of 30 was reached. We just missed the one on public facilities that are maintained, repaired, and refurbished just by one, because we had a target of 300. We then got 299. There was just the facility that did not present the maintenance completion certificate on time. However, in the new financial year, they actually did submit this, but however, it was then late. So we are managing the issue of the submission of these project completion certificates going forward and monitoring it monthly. The hospital strategy concept document has been recommended for NHC. So coming to the last program, the health system governance and human resources program 6. So we had a target of 3 boards or councils appointed for the new term of office. That was South African Pharmacy Council, the Nursing Council, and Medical Council for Medical Schemes. We had an additional board appointed for the interim Traditional Health Practitioners Council of South Africa, which followed the resolution that was taken that it must be appointed within 3 months after their meeting in February. The biannual governance reports were produced. The 9 public nursing colleges were supported to develop curricula and prioritize nurse and midwife specialists. The National Health Quality Improvement Program has been expanded more extensively than we had thought initially. So hence the targets have been exceeded. In terms of the ideal clinic, we had a target of 2,600. We reached 2,706, exceeding the target. For the review of the food label regulations, we had the comments coming in, captured and analyzed. However, we could not finish the process because the stakeholders requested an additional opportunity for comments, so the period had to be extended. Then when it comes to the recommendations of the reviewed community service policy finalized in terms of human resources for health, the presentation was made to take NHC in March. However, it recommended that more work be done before it could be finalized. Then the next target talks about the rollout of the Human Resource Information System in 30 districts. We exceeded this target by 8. So for the, in order to process the comments on the draft food labeling regulations, we have received the donor funding for support. And then for the community service policy, the review has taken place in the new financial year with an intention to strengthen the service delivery, needs, inclusive of all professional categories, social obligation for employing professionals by government, and shared services platform with social cluster departments. So then in terms of the summary for the department, we had a total of 48 indicators, and we were able to achieve 28, which makes 58%. Then just on the human resources, just to indicate that we have got 1,122 position on the approved establishment. And we are indicating here that our vacancy rate is currently standing at 24.1%. This is partly related to the budget cuts we experiencing, in which we have to prioritize posts, and some of them we are actually not able to fill. I will stop here for the CFO to take over the financial management. CFO, do you want me to continue with paging the slides?
Yes, thanks, Thuli. You can continue with the slide. Good afternoon, Honorable Chair, members, the Minister, Deputy Minister, and colleagues. We can go to the next slide. On the first slide, we're showing the expenditure, the overall for the department. We had the final appropriation budget of 58.5 billion. And we did spend, in terms of the actual expenditure, 58.3 billion. We also do show the budget available or funds available of 237.8 million. Then in terms of the percentage, the spending is 99.59%. When we compare the spending to 2022-2023, which was 97.4%, so we have improved. Then we'll also indicate as we're going to proceed with the details. But the lowest spending program was program 2, which is NHI. On the next slide, we have the same figures, but in terms of economic classification. The next slide. So in the next slide, Honorable Chair, we do show the same expenditure. And then you'll see the underspending was under goods and services with 71.6%. In previous financial year, and in the current year, we have improved to 87.4%. So what I want to indicate here is that the underspending of 237 million is because we were still waiting for most of the invoices by the financial year end. We can also confirm that the accruals for the same financial year, it was 243 million. So if we had received all invoices, we would have been able to pay or utilize the whole budget in the department. On the next slide. Here it's only the reasons for deviations, especially in terms of compensation of employees, because of the austerity measures that we had from Treasury, and also in terms of goods and services. Some of those invoices that we could not pay relates to rental on our current building, Dr. A.B. Kuma. We also did have some of the invoices in terms of improving the smart boardroom, the data and information technology. And then in terms of the capital asset, we did spend all the budget. Then in the next slide, we're going to start indicating the expenditure in terms of sub-program in each program, starting with program number 1. And that's where we're paying most invoices for the rentals in terms of the building. And then here, the spending is sitting on 92.8%. Then we do have the sub-programs as we have indicated. So I'm not going to indicate all the figures, Honorable Chair, but the budget was 730 million, and we did manage to spend 678 million. In the next slide is program 2, which is NHI. So what we want to highlight in this program because we also do fund the provinces in terms of conditional grant. So in this program too, we do have a portion that we send to provinces in terms of HP contracting, mental health, and also the oncology, which we have within this program. But then also because there was a limited capacity within the program in terms of employing the staff, and hence there was also the underspending in the related goods and services. Program 3, which is our communicable and non-communicable disease. This is our biggest program. In here, Chairperson, I'll only want to highlight the item number 2 in terms of HIV and AIDS and STI, where we have 23.3 billion. So that is the money which we had allocated to the provinces in terms of conditional grant, but we will also indicate the details. In this program, the total budget was 23.7, and we have managed to spend 23.6 billion. In terms of percentages, 99.73%. And then in the next program, which is program 4, which is primary health care, and also in terms of line item number 2, the sub-program under district health services, we are also funding the community health workers, which they are in the provinces as part of the conditional grant that we send to the provinces. And the spending in terms of this program is 99.8%, with only 4.2 million rand remained unspent. And in our program 5, we do fund also in terms of the conditional grant under sub-program number 2, which is health facility infrastructure grant, and also in terms of hospital services. That's where we fund in the provinces in terms of the NTSG, which will still find it. We'll still present the details in terms of those conditional grants, but the total spend, it was 99.9%, which is almost 100%, which 5.1 million rand remained unspent. Then the last one is program 6. So in the program 6, we also do fund the public entities under the public entity management sub-program, which is sub-program number 3. And then we also do have the women resource for health, sitting at 5.5 billion, which we also fund to the provinces. So the total spending for this program was sitting on 99.6%. The next slide, Honorable Chair, is going to be on the conditional grant, where the next slide, we indicate in terms of the overall spending on the conditional grants in the provinces that the conditional grant was sitting on 98.5%, or the 52.6 billion rand that we have spent. So here, just to also indicate in terms of the bullet number 2, that we do have the preliminary rollover approval of 604 million out of the 812 million underspending, which could have made it 100%. So when we take into account the preliminary approval into the actual spending, then the spending will be sitting on 99. And yeah, then the other slides, the information, they will just indicate the other conditional grants where there was no huge spending in terms of the NTSG and the HR component and the HIV and AIDS. But then you'll see in 3 of them, there is a housing underspending, and also that the health facility revived NHI and training component they've spent within the norms. So the next slide we only show in terms of each conditional grant spending in terms of all conditional grants in total, without going to each Honorable Chair, because in the next slide we do unpack, but just to highlight that we did have a national adjustment of 1.4 billion. And then we also did have the provincial rollovers that we received to 690 million. In the next slide, we go in terms of each. Okay, the first one is in terms of the total provinces. How they have spent 94.2. I think we will, as I'm going to indicate per each conditional grant, you will see the spending that contributed to 94.2, while the other provinces, you realize they spend 100% or 99.7 and so. The next slide, which is the NTSG, you'll see all other provinces, they have spent 100%, except Gauteng, which they have spent 88.2%. And then the budget available there, it was 618 million. But out of that, Honorable Chair, you will note that there is a rollover that is preliminary approved. Towards the end, I'll also indicate how much is that. The next slide is a district health program grant. So within this, we do have two sub-programs. The two sub-grant, which is HIV and AIDS and community health services. Go to the next slide, which is HIV and AIDS. You'll see in terms of Gauteng, they spend 96.7%. So in terms of other provinces, Chair, I'm not indicating because you can see the spending is 100%. And in terms of the total here is 188. The next, which is the community health workers, also the next slide. You'll see the spending in terms of the whole grant. There's been an over expenditure, but then the provinces will absorb such over expenditure within the equitable share. The next slide, in terms of the next is statutory HR or the HR for health. Then in terms of this one, the spending is sitting on 99.5%, so it's almost 100%. You'll see we only had the Gauteng with 25 million underspent, but you also realize they did receive the provincial rollover of 27.2 million. The next slide. The next slide. I think the other, it's just showing the two component of that grant. The next slide is the training component. And then in terms of the health facility revitalization grant, the province that has improved is Gauteng, which now they're sitting on 99.5%. But in terms of other provinces, you realize the spending is 100% and the total spending here is 99.8. Then the next slide, which is the NHI. In this grant is the one that I've indicated, Honorable Chair, that we have been funding the oncology component. We're also finding the mental health component and the HP contracting. So the main underspending within this is inability of the other provinces to attract the specialists and general practitioners, because the HP contracting is for doctors that goes to the PHCs. Then we also have the mental health, where we also fund the specialists and also the oncology for improvement of tertiary services in the provinces. The next slide. These are the National Health Insurance Grant. These are the indirect which are managed within the National Department. Then we also indicate in terms of all the components of grants, Honorable Chair, which I'm not going to go in terms of each. So the available budget, including the commitment, it was only 4.3. So we did have invoices which we could not manage to pay towards the end of the financial year. And then also when you exclude the commitments, it's sitting on 52.3 million. The next slide, that is the slide, Honorable Chair, I was indicating the preliminary approval rollover request, which we did from different provinces through their provincial treasuries and national treasury. So out of the 812 million underspending, so we're going to receive the 604 million, which has been preliminary approved by treasuries. So that will be the money that will come back to the sector. And then you will see in terms of each province, mainly in Gauteng, where there was underspending. The next slide, it should be on the audits. In the audit, Honorable Chair, we will want to highlight the improvement in the sector. In terms of Limpopo, you'll see that they've been receiving the qualified audit opinions, but currently they've received the unqualified audit. Then in terms of Eastern Cape, they're still qualified in terms of contingent liability, and in terms of Free State, they're still unqualified in terms of immovable tangible asset and expenditure of capital asset. That's the issue of classification. While Gauteng continues to receive the unqualified, and also the KZN, which it has improved in 2022-2023, they've maintained the unqualified. Limpopo have already indicated the improvement, and Mpumalanga that they've sustained for the 5th year, with Northwest for the 4th year, while Northern Cape, they're still struggling also to achieve the unqualified. And just to appreciate the Western Cape, because they've been receiving the clean audit, and the National Department, Honorable Chair, that we have also received the unqualified. So there will be some of other issues in terms of compliance within the different departments, within the different provinces. That was the last slide, Honorable Chair, so I will take it back to you, DG. Thanks.
Thank you very much, CFO. Thank you very much, Honorable Chair. The members, I will hand back to my minister. Thank you.
No, thank you, DG. I'm sure, Chairperson, we are at your disposal to answer questions. Otherwise, I don't have anything to add on the presentations that were made. Thank you.
Thank you very much, Minister, and your team. You have been very economic with your time, and I think we'll really be able to get into your time that you are really needing to be released at your time. Honorable members, may I request that we give a maximum of 5 questions. If you have 6, just keep the 6th one. We'll come back to you in case there are members who go to 3 or 4 questions. But let me then recognize by hands. Right now, I see the first one will be Honorable Dr. Leroux, followed by Honorable Van Staden. The third one, Honorable Shabangu. Those are the hands I have for now. Honorable Motubatse, you are number 4. Honorable Dr. Tembekwayo, number 5. Honorable Sene, you are number 6. Is there anyone I'm leaving behind? Honorable Dr. Letape, you are number 7. Okay. In that order, honorable members, can you please assist me? Do a maximum of 5. We'll come back to you if there's any of these members who are doing 3 or 2, then we can come back to you. Start with Honorable Dr. Leroux.
Thank you very much, Chair, and thank you for the presentation by the National Department of Health. I think I've got exactly 5 questions, so hopefully I can get through them quickly. My first question is around the indicators, particularly related to TB. I think that's a very useful indicator because it's a clinical indicator, and so I like that indicator very much. But as you've indicated, I'm quite concerned about the underperformance in that area. We can see that about 43,233 people who we expected to treat, we did not treat at all. So 20% of people who we expected to treat, we didn't treat. And then of those people who we treated with drug-sensitive TB, only 71, there was only a 71% success rate, and even lower in multi-drug resistant TB, which means that just over 60%, which means that nearly 40% of patients with multi-drug resistant TB are still out in the community spreading TB when they haven't had successful treatment rates. So I just, on that specific, on the TB issue, I'd really like to understand what has gone wrong there. I see that you are looking at that, but I'm hoping that you have some information about that, and also really hope that you can tell us what the plans are to improve that. Then I think I'd just like to explain the Department of Health, to explain just the lack of proper consequent management, as has been highlighted by the Auditor General. We see that in a few things. So we'd like to get a feedback on the Digital Vibes report, which hasn't been given to us yet. So we'd like to know when that report will be made available to the PC on Health. We'd also like to find out when we will get a full report on the regular appointment of Brainwave Projects SA for the satellite internet at primary healthcare facilities of 122 million rands, and what the consequence management was there. And then finally, we'd like to just understand why the department has not yet intervened in Gauteng with the massive corruption flagged by Babita Decorum and which led to her murder. We also know that none of those, it's been indicated that there haven't been any companies that have been blacklisted. Why have they not been blacklisted? What has been the consequence management there? Thank you very much.
Yeah, thank you very much. A reminder, honorable members, just like Dr. Leroux, if you are able to switch on your camera, please do during the time you are presenting. Honorable Van Staden.
Thank you, Honorable Chairperson. I'll stick to 4 questions. 359.3 million is disclosed as irregular expenditure, but includes 150 million that was paid to DigiVibes, the 19.1 million in unauthorized expenditure, and fruitless and wasteful expenditure of 870,000. Can we please get an explanation for this, and when will this committee also surrounding the DigiVibes report, when will we receive this investigation report from the department, as this is a few years that this matter was handled by this committee, and I think we need to see the report by now. My second question is that this department received an unqualified audit with findings, and the AG found that financial statements submitted for audit had not been fully prepared in accordance with a prescribed financial reporting framework. So my question is, what is the challenge for the department in getting this right? When I have this question for the minister, excuse me, in a recent question, I asked the minister regarding the total amount spent on advertising costs on NHI campaigns, and the minister replied to me that the total amount of 89 million was spent, of course, over a period of time. And 77 therefore million was for DigiVibes and 11 million for KMT agency. I just want to ask the minister if he can indicate if this spending can be justified, and if so, why? And then my last question, Chairperson, on the compensation of employees, can we as a committee get an update on the impact the reduction in spending is having on this department, and which critical posts are still not filled, and what plans are in place to mitigate the impact, and has National Treasury been approached regarding this matter? Thank you very much.
Honorable Shabangu.
Of course. Thank you, Chairperson, and good afternoon to everyone in the platform. I've partially covered on the other questions, but then we also appreciated the report that has been presented to us. On the AG's report, there's repeated outcomes, and there seems to be no action taken by the department over the years. I hope when they are responding to the questions, because other members have touched on it, we will hear of the challenges that the department is encountering in addressing this irregular expenditure, or all the repeated outcomes by the AG. And also, one would like to know and understand, how will the department implement the AG's recommendations to strengthen the internal controls, improving financial management, and creating a culture of accountability in the department, in the provinces across. And also, what are the key factors contributing to these varying audits outcomes, as we have been getting the report that is across the provinces? And what are the strategies that the department has been employing to support provinces like your Eastern Cape, your Free State, and Northern Cape? And how are these strategies being viewed, considering that there has been no improvement on the audit outcome? And the next one, Chair. What oversight and support mechanism are in place to ensure the clinics that obtain ideal status do not regress? And we note that the ideal hospitals initiative lack formal monitoring compared to those of ideal clinic. How does the department intend to address these disparities? Thank you, Comrade. Thank you, Honorable Chair.
Now, on the last question, Honorable Shabang, we were only seeing your fingers, but we heard your voice. It was fingers in the voice that were there. Honorable Mutubatsi?
No, thanks. Thanks very much, Chair. And we must actually welcome the report by the department. I have a few questions. One, I think in our last engagement, the minister promised to bring along, I think, the concrete report regarding the pilots that are currently unfolding in the provinces, in particular in the QwaQwa regarding digitization. If maybe the minister can actually indicate the start and the end date of the pilot so that we can start rolling out full-blown regarding this migration. Secondly, just if the department can clarify with regard to the community health workers, because they are a very important component, especially in the communities. But what you are picking up is that they are on grants. I mean, they are on PESAL continuously. But I saw on the report that they are on, I mean, there's a grant that was actually put forward, but then it was ultimately, maybe it can be clarified around their status. That would be of interest. With regard to the PHC, the department has indicated that they have exceeded in terms of the actual performance that they've put forward before. But, you know, I was in Gugulethu Clinic this past week. I think the status there is really very bad. If I was to take a decision, and I did share this earlier, if I was to take a decision, I'll immediately zoom into that clinic and close that particular clinic, because it's not only a danger to the workers that are there, and I'll want to take this opportunity to appeal that the management of the department must quickly zoom into that particular clinic and see what can actually be done there. Like I'm saying, the situation is so the status that is actually there in terms of achieving what criteria or what are the key points that you can say makes us to be satisfied that we are at this point, this particular clinic can actually be regarded as being ready in terms of the criteria for meeting the PHC. On the third question will be on the accruals that are there, that are in the department, I mean in the provinces. What is the department planning to do to mitigate these accruals that are there, because they obviously affect the baseline in the coming financial period, so that they're actually encouraged to deal with that particular issue, because some of them are as a result of incapacity, and some of them are as a result of irresponsibility. Now, one last thing that I want to ask the minister, when are we actually bringing back the alcohol bill that was actually put aside, I think, for various reasons? And I would actually want to mitigate that that bill should actually be brought in back, like we discussed in our in our last meetings where I made this particular input, but I want to hear the minister, I think, talking to bring back that alcohol bill onto the table so that we can facilitate it. Thank you, Chairperson.
Honorable Dr. Tembekwayo.
Thank you, Chairperson. I just want to find out, I've switched on the video here. Is it showing? I'm
Not,
asking. It's not showing.
not yet.
Oh, not yet. Then it's a problem. I don't know what to do.
Can hear your
But
voice.
okay, but let me continue. If you allow me to.
Yes, do, ma'am.
I just would like to say that there exist a lot of acting positions in the health sectors, inclusive of hospitals and or clinics. Some of the executives that have been in those positions are there for a period of more than 3 years. And this has been demonstrated during our recent oversight visit to Northwest. And when we ask about why is this happening, they put the blame on your department. My problem, the fact is, how would you provide urgent intervention so that these acting positions are filled accordingly? The second one is the problems that exist within the entities that are serving under NDOH. There exists a lot of staff dissatisfaction from their executives. Yes, we agree that staff dissatisfaction or satisfaction surveys are being conducted and findings are arrived at that point to unsatisfactory treatment from the executive towards their employees, irrespective of whether the survey has been filled, interpreted, and so on. But there is no change of attitude by the executive towards the employees. I would also ask to say, how would your intervention in this regard be, so that if we have the working condition of the staff being very positive, then we'll have definitely better results that will derive it. My last question is based on the AG's findings that attest to the financial statements submitted for audit that had not been fully prepared in accordance with the prescribed financial reporting framework. And the worrisome factor is it's a repeat findings that includes, the management that do not implement proper record keeping, just a mere record keeping in a timely manner to ensure that the complete, relevant, and accurate information was available to support the financial information and performance reporting. Obviously, this results in the materials findings. The management that does not implement controls over daily and monthly processing and reconciling of transactions to ensure accurate and correct reports. The management that does not adequately review reports achievement. The management that does not adequately do the indicators according to the targets to ensure that they are clearly defined during planning processes. Yes, you give us all this information that is there, but when it comes to doing the proper thing, it's not done so. And it's always the AG's office that will find out about this information that is there. If it's the NDOH that is doing such mistakes, what about the entities? What about the province and the district? I mean, you have to show by example. Question is, what is the challenge for the department in getting the above that I've mentioned correct? Thank you.
Honorable Sen.
Thank you very much, Chairperson, and good evening to everyone in the platform. Chair, I have two questions. Number one, considering that 2,100 primary healthcare facilities have youth zones, what is the data indicating regarding the interaction rate and the impact it has on HIV prevention among the youth, HIV and STD infection rates, and also treatment adherence in those regions? And then, Chair, number two, in terms of the health patient registration system, I would want to know, when will the department fully implement the health patient registration system in all healthcare facilities, and what is it that will be done to address the issues of underutilization, sinking, and also connectivity? Thank you very much, Chairperson.
Thank you, Honorable Tofale Tlhape.
Thank you, Chair. Just a few questions. The first one, can we get more information around, acknowledgement to the Chair, good evening to the Minister and to the DG and staff members, and thanks for the report. Information around the contracting arrangements around the pilots for NHI, the CAPS, how they work, what quantums, assessment of value for money, etc., so that we could get to know how this has turned out. Second issue, Gauteng outsourcing oncology services, Charlotte Maxeke Academic Hospital, in terms of the fire, where are we with it going back to full functionality? And along the same vein, we've had reports from the previous Ombud about Rahima Musa Hospital, the social outburst of Tom Ford and Helen Joseph. And we just get alarmed by the fact that there's complete expenditure, which is great, but we don't seem to be having infrastructure improvements or quality of healthcare. And in some places, as we saw in the Northwest, there are challenges with water services. The third question is around the patient load from foreigners in our institutions. I mean, most of the maternity services that we have, one of the CHCs we attended, more than 50% of the patients are foreigners. Rahima Musa Hospital, it's the same. How are we going to be paid for this? Are we budgeting for them? How are we going to manage the issue of the patient load on our infrastructure, and how are we planning for it? There's a recent decision by the Supreme Court of the USA around COVID vaccines, and we haven't had a fireside evening from the president and a report back post-COVID. Is that likely to occur so that there could be better preparedness and better compliance from society, because they are being informed about what the outcomes are, where we at, what did we learn, and what would we be doing in case of the next emergency that would arise. Lastly, concern about appointment of the CEO for Chris Hani Baragwanath Hospital, where there's allegations of irregularities around that appointment. Public Service has said they would investigate. But what is the Department of Health doing around that issue so that it becomes resolved? As the minister always mentions, that's the third largest hospital on this planet. And if we have an inappropriate appointment in that position, it would be a serious calamity. A lot of the biggest patient load on a hospital is on that hospital, and also large liabilities in terms of litigations come from there. What is being done about that appointment, just to ensure that it is investigated and corrected if needs be? Thank you, Chair.
Okay. Thank you very much, honorable members. Minister, the presentation of the Office of the Ombuds yesterday indicated that there are probably certain similarities with regards to what is his findings on complaints that are coming into his office with what actually you presented to us on medical legal claims, largely coming in from these provinces, Gauteng, KwaZulu-Natal. This time, Eastern Cape was not featuring very much on that one. Now, and him being a very experienced clinician was probably saying there's quite a lot that the department should actually dig into to assist us with all these reports that do come in, National Coordination of Maternal Inquiries and other related, to strengthen, because when we went to Northwest, we found that we have got 2 district hospitals there that have not recorded maternal deaths for 2 years. Now, and then we wanted them to educate us. What are you doing? And they really gave us a lot of information, fire drills, sharing of information, always available to share and assist and go for training. Now, we wanted to say, but Ombud, you do have frequent meetings with the minister. Do you share these issues, these success stories, and these other gaps that you find so that you could actually nip? So what I'm saying, the complaints that are in his office are coming largely from the provinces where, Minister, you are also getting many medical legal claims and those challenges. So, and then number 2, who do we actually hold responsible in South Africa when it comes to food services that are not in a good state in the streets? I know it's environmental health services. Now, where do we fit in there? Where does the department fit in there in terms of making that sure that that thing is being attended to? The issue of environmental health, how far are we? How far is the department on that process? Could we go and actually do it with municipalities, or should we wait for the department to really support and make sure they work with municipalities? The third one from my side would be your programs related to TB and how, I mean, there was a very good report that came from the South African Medical Research Council, their readiness to support the department and lead in the global south, especially when it comes to G20, with things that they will prioritize. Talking to what the president was talking about this afternoon, G20 programs on health. Have we started on that as a country, as a continent, making sure that you would have certain things that you would want to remain as a legacy of the continent, of the country, within the space of G20 on health? If maybe Minister could maybe touch on those, we will appreciate your contributions with the leadership of the department. Thank you very much. Over to you, Minister.
Thank you very much, Chairperson. We will take the questions one by one because I would like to direct which ones will be asked by officials and which one I can take. And the Deputy Minister will come in wherever he wants to make an intervention. Starting with the doctor from Dr. Carl Leroux, can the DG take the first 2 questions? I will take the question on the issue of intervention in Gauteng and the death of Babita Deokaran was quoted. DG, can you answer can you and your team answer the questions from Dr. Leroux, please?
Thank you very much. Thank you to the honorable members for all the questions. We really appreciate. I would like to request the the CFO to deal with all the AG-related questions that came from Dr. Leroux. But safe to say that on the digital vibes, consequence management and for all the report that came firstly was for the president from the SIU, and it was referred to the minister then.
DG, that question was not asked by Dr. Carl Leroux. He never raised
under his name
about digital vibes. We're still on Carl Leroux. I want us to finish that so that we take them systematically.
Oh, okay.
No, he did. He did ask about digital vibes. I've also noted it. Yeah.
What did he say?
Well, he wanted a report.
I would just, Honourable Minister, I was asking about when the digital vibes report will be available for the Parliamentary Committee.
Oh, I see. Okay, I missed that. I'm sorry, DG. You can go on there.
Yes. No, thank you. The report was actually produced for the president by the SIU, as they produced the report for the president, and it was referred to the minister, Minister Pasha, and there was consequence management on a number of officials.
DG, you are dying off.
Hi, Minister. Am I getting lost?
No.
No,
Your connection was starting to wobble.
Oh, okay.
I wonder what you have changed.
No, I'm better now, Minister.
Yeah, it's better.
Yes. No, thank you. I said, well, the digital vibes matter, it was an SIU report, which was referred to the president. The president referred it to Minister Pasha at that time, and all the consequence management was carried out during the last administration. And then I would like to request the CFO to deal with all the issues around the audit that came from Dr. Leroux, and then for Mr. Moriwane to talk on the TB indicators. Thank you. CFO?
Thanks, DG. I think one of the questions that I've noted, Dr. Leroux, he mainly mentioned the issue of the intervention in Gauteng, which included Babita, which the minister, he said he will talk to those DG. Thanks.
Okay, Mr. Moriwane on the TP.
Good evening, Honorable Chair, Honorable Members, Honorable Minister, Deputy Minister, my colleagues on the call and other members. The questions that came from the Honorable Leroux, the concerns about the performance under TB, and as we have indicated in the report, Chair, that we do find that there are a number of TB patients that arrive in the facilities with an unknown HIV status. And we've noted that the treatment outcomes are not very good in that area. And most of them, that particularly HIV and AIDS patients that have disengaged from care, when they return for treatment and are tested and they test positive to TB, they do demise within 3 weeks. And now what we have decided to do in terms of an intervention is to then, as it is in our guidelines, to have a mandatory testing for everybody when we, for an example, receive patients back and link them to care for TB. Mandatorily, we test them for HIV. And when we re-engage for HIV, we test them for TB so that we can start the treatment at the same time. We do know that with regard to testing, indeed, the number 43,233 is a bigger number. We do say it's a proportion of 223, where we have 108 of them that we've tested. But there are those that, the 43, majority of them are those that are not initiated straight away. They may choose to go home and say it or come back. They may choose to give many other reasons. Some of them don't return. And there are those where we need to intensify our social behavioral issues. That is why in our TB recovery plan, we're emphasizing social behavioral community change and engagement as mechanisms to reach everybody. And we also do want to reach out to the families and working together with the community healthcare worker program so that we are able to reach out to families and educate both communities and families around the need to test for TB, the need to initiate treatment straight away, but also the need to stay on treatment so that they can complete the treatment, the course of the treatment. Yeah, so thank you very much, Steve.
Thanks, Mr. Morewane. Just to add to the answer, actually on TB, most important issue is people presenting early and being started on treatment early. Actually, why we have
switch on your video, DG.
Oh, my apologies, Chair. Thank you very much. No, I was saying on TB, a lot of work that we're doing around the TB recovery plan is to actually go out and test people outside there and put them on treatment immediately. And also we've now extended to even doing a screening using the mobile chest x-rays so that we can get as many people as possible. Our issue is actually ensuring that we keep people on treatment. Hence, the actual treatment outcomes become a problem. And the treatment success rate is a combination of treatment completion plus cure rates that gives you the treatment success rate. And that's what we are working on. And if we can improve on that, we think we can do better on TB. We do agree that it's not how we should be performing as a country. But we're probably, when we report the next time, would have done much more better on the TB with all the intensification that has been put in place working together with SANAC. Thank you very much. I'll hand over to the Minister.
Thank you very much. Yes, the last question here was the issue of intervention in Gauteng, and the question of Babita Deokaran was quoted. I just want to bring to the attention of honorable members that this. Yeah. Sorry, yes, thank you. I'm saying I just want to bring to the attention of honorable members that these cases have already got attention from the law enforcement agencies. As you know, the Hawks, SIU, NPA, and all the other law enforcement agencies are all involved in Gauteng. That's the first thing, and we'll hear from them what the final outcome or the final decision is. The second thing, when things like this happen, honorable members, there are two courses of action. Firstly, the law enforcement agencies, as I've already said. But then the second one is consequence management inside the department. There is a general belief, which is wrong, that because we are national, we have got power over disciplining, over the HR issues of provinces. We do not have, unfortunately, honorable members, except where there's cooperation, where they take your advice. But in terms of legally, that we can hold something against a province and say punish so and so, it doesn't work like that. I know it's difficult to accept, but that's what the laws are saying. I also don't like them, and I think these are parts of the laws that need to be changed. For instance, we get lots of people who lodge complaints that the provinces have unfairly dealt with them during DC or have even fired them, and they appeal to the minister. There is no legal mechanism in South African law that an employee who was fired in Gauteng or disciplined in Gauteng and left off the hook or fired after discipline, there is no legal recourse of the minister to go and intervene there. The law says if, for instance, the employee went through a disciplinary hearing and got fired, their only recourse is to go to CCMA, not minister. There is nowhere where the minister enters, it's the CCMA. If they are not satisfied on the CCMA, they go to Labour Court, and that is the end. After Labour Court, they can't go anywhere else. So the ministers are not involved in that process, and that's quite unfortunate, but it's exactly like that. So if the law enforcement agencies instruct Gauteng, for instance, to do a DC on these cases after they finish their criminal investigation, If Gauteng doesn't do anything, the minister cannot necessarily intervene except to go and lodge a complaint with the premier, talk to him and encourage him to take action. Beyond that, the law does not allow us any entry point. I just wanted to bring that to your attention. And I'll then come to the question raised by Honorable Van Staden. DG, will you take the others and I'll answer about the issue of 77 million rand in digital vibes.
Thank you, Minister. CFO, there is an issue of irregular expenditure, fruitless and wasteful, and the financial statements and the impact of cost containment on COE. CFO, can you please come through? Thank you.
Yeah, thanks, DG. In terms of the question on the accruals for the National Department of Health, I can confirm the amount that was indicated of 359 million. It was the irregular expenditure in the previous 2-3 years. I can also confirm that in 2022-2023, and also in terms of previous year, which is 2023-2024, there was no irregular expenditure which has been identified in the National Department, and also the fruitless and wasteful expenditure. I think in terms of that, there was a question which spoke to the digital vibes, which is the issue of the investigation. Even in the report from the AG, I can also indicate, Honorable Chair, that as a National Department, we have done the investigation of the remaining cases. It has been reported from the AG, but however, at this stage, we are busy implementing the consequence management for the rest of the other transactions which they've been in the department for over 5 to 10 years. The other question was relating to the AFS, and that they were not prepared in accordance with the MCS, which is the modified cash standard, which we use as we prepare our AFS as the National Department and the provinces. Currently, DG, we have capacitated the internal audit. So we also make sure that they do the internal audit on the AFS in terms of our interim audits. And also even at the end of the financial year, we have the teams to strengthen the process of review so that we don't have any material adjustments during the audit. But also in terms of the provinces, honorable members, they've raised the same question. Just to also indicate, we do have the CFO's forum where we do discuss the audit outcomes and the issues from the AG. We have also established the 10 by 10 committee, which is the 10 departments of the provincial departments and national department, including the provincial AGs and the national AG, where we meet and discuss the audit outcomes, and it has assisted in clearing some of the issues, including the qualification that the Limpopo had in the previous financial year. And we also encourage the provincial treasury, the offices of Accountant General. Currently, we have been talking with the Northern Cape to ensure that we assist together from the province and the national department and support the province in terms of improving the controls in the department. The impact on the COE, the issue is that since we have not been able to make the appointments, DG, because of the reductions from the provincial treasury, so that it has affected the department and the sector. We do have the slides, which was not part of this presentation, which it does indicate for the sector for the past 2-3 years, we have almost lost 18,000 posts within the sector. And also, if you look in terms of the budget growth, which there was another question, is that the budget growth is lower than the normal increase in terms of the compensation of employees. So there is a reduction, and the impact is that is reducing the headcount within the health sector. Thanks, DG.
Thank you very much, CFO. Just to add specifically at head office, we had prioritized 101 posts fulfilling because of people that have left. But also we've got a new branch, NHI, where you needed to fill positions, and we're only allowed to fill 60 by Treasury. So it really has an impact on how we function as a department. I will then hand over to my minister. Thank you.
Yes, I just wanted to deal with the last question by Honorable Van Staden about the question which I answered to Parliament, written questions on the expenditure on adverts. I remember that very well. Yes, we said the lion's share at 77 million rand was for digital vibes, and the question is whether it was value for money. And the answer is it's not, because I mean there was an irregularity. That's why the SIU came in. That's why you came to hear about digital vibes, because the law enforcement agencies were moving in. They would not have moved in if there was no problem at all. Thank you.
Continue moving on, Minister. Now the next question of
Yes,
Shabangu.
Now we are on the questions by Honorable Shabangu. I'm sorry, Chairperson, I slipped a bit there. Honorable Shabangu, please. DG, there are questions there about repeated regular expenditure. I'm sure it's the same as the question that was answered by the CFO, but I'm leaving it back to him again.
Yes, and the strengthening of internal controls, and he's already covered it, including the support to provinces. I must say, we've maybe just not to bring him back because we've been working together. One of the things that we've done in the past year, we've appointed more than 3 internal auditors to ensure that we have a lot of capacity internally to ensure that there is stronger internal controls, and they also deal with issues of the outcomes coming up with the audit action plan that we deal with. And support to provinces, CFO has already put up that there is a CFO's forum, there's a 10 by 10 where we meet with different provinces, with the different AGs, different treasuries to deal with the cross-cutting matters that are in provinces. And that's why actually, as we mentioned, we've been able to turn around Limpopo quickly because there was that cooperation between ourselves. But in addition, we have a dedicated chief directorate called Provincial Support, led by Mr. Hadley Nebutalu, whose jobs is to just work with the provinces on financial management, strengthening procurement, ensuring that everything is done in order. And then the last 2, I will leave to Ms. Jeanette Hunter. There's a question on the sustainability of ideal clinics, and then thereafter followed by Dr. Matati on the ideal hospitals, on why there is no monitoring. Over to you, Jeanette. Thank you.
Thank you, DG. Also, good afternoon to the Chair, honourable members, the Minister, Deputy Minister, DG, and my colleagues. DG, the way I heard it was there was a question, why does the hospitals not have the staff or supervision like the Ideal Clinic has? I also just have to say that the Ideal Clinic doesn't really have dedicated supervisors either. Because of the problems that DG has highlighted, our inability to fill posts, even though we have money, we are not allowed by the DPSA and Treasury to fill posts. The people who do the coordination of the Ideal Clinic progress in the provinces, they are doing it under strained conditions because they have other responsibilities, but they take on a number of provinces and work with the provinces to ensure that there's progress with the clinics. So I'll stop at that, because the question was, why does the hospitals not have the same supervision as the Ideal Clinics, DG?
Yeah, and how do we prevent PHCs from regressing from an ideal status?
That is continuous follow-up supervision. There's district teams in all the 52 districts that visits the CHCs. And as the honourable members know, that framework has got the individual elements So one has to consistently make sure that the facilities, and in this case, the CHCs, remain with green elements. For example, if they've always had oxygen, they've had their, all the equipment, they've had their medicines up to the levels that is expected. It's continuous monitoring, as I say, at great cost from those national colleagues that actually volunteer to go out with the provinces and make sure that facilities keep on having those elements present in a positive way, DG.
Thanks, Jeanette. We'll hand over back to our minister.
Yeah, thank you very much. I think we are moving over to questions by Honorable Mutubati. The first question is about the concrete report about pilots. And I think as I listen to him very carefully, he's talking about the pilot on patients record management system. And I think Dr. Chris could help us on this one.
Yeah, thank you very much. Good evening, Chair. Good evening, members. Good evening, Honourable Minister, Deputy Minister, and colleagues. So, yeah, thank you very much. The answer to this question is that we are currently this week and next week we've been busy preparing this week and are in the field next week with the beta implementation in Ditlabeng, which is in Bethlehem, so as the Honourable Member said, in QwaQwa. And then in terms of where we are going with this project and the implementation, by the first week of December, there should be one site in each of the 9 provinces where the new electronic medical record should have been phased in at the beta implementation, it's called. We are aiming to have 100 facilities in this phase, but the rollout proper will start after that in January. The speed with which we are able to roll out to facilities is dependent on the resources we've got, and that includes not just the money and the budget, but also the number of people who do the training and show people in the communities and the facilities how to use the system. The good news is that for the first time, we are installing this system in both public and private facilities. So there are GPs who are already enrolled and will be using this system. So it's all systems go at the moment, and we will monitor it very closely to see that it goes on track. Thank you, Honourable Minister.
Thank you very much. I think we should continue on the other questions, DG. Community health workers, Guguletu clinics, accruals. And I'll answer the last one about alcohol.
Thank you very much, Minister. In terms of the community health workers in the except for Gauteng, in the 7 provinces, they are on PESAL and not as full-time civil servants, but they are paid through the grant that the CFO presented. This is based on an agreement that we had at the Public Service Bargaining Council. And that agreement is to expire in March next year. So we are looking at the modalities. But for now, the grant is still there. Except then the one province that is doing something different is the Western Cape province, where they still have their community health workers contracted under the non-governmental organizations. And they believe that that modality is working for them. So the matter is still at the Bargaining Council, and we are under the guidance of our political leadership looking at modalities on what would happen when it comes to March next year, whether we extend the contract and continue paying them. The reason why we had to pay the CHWs on PESAL is because we wanted to standardize, and we pay them just above the minimum wage as put by the Minister of Labour. And we wanted to ensure that they all get paid at the same time, because previously you'll hear that in another province they earn 500, in another province they earn 1,500. So the issue of putting them on PESAL was to ensure standardization, payment on time, and the right amount of money that is above the minimum wage. So that is the status. So the status is different. Gauteng went ahead and employed some of them permanently on different posts, and that's what was the provincial decision. But the National Health Council is still dealing with the matter to decide on how we go on as we move into the future. I don't know about the issue of Gugulethu Clinic. It's a specific matter. I don't know if Jeanette maybe has got a response, because it's a very specific matter about the clinic that we should probably visit and then be able to come up with a response to the honorable member and the portfolio committee. We'll try and see if it's possible to do that quite soon. And then the accruals in the provinces. The main issue of accruals is really a headache for the health sector. And most of them are mainly due to the medical legal claims. And the most hit province is the Eastern Cape. And we're trying to assist them, but it's very difficult to see how we can deal with the matter, because every year when they start the year, they are already on the negative. And then by the middle of the year, they can't keep up with the payment of their obligations, and then there is a disruption in supply chain for drugs and all those matters. So it's a bigger matter that we're raising with National Treasury, because then it perpetuates the problem. Every year you carry on the debt as you move forward. So that will be my response, Minister. I will then come back to the Minister. Thanks.
Thank you very much, DG. Honorable members, on the issue of community health workers, I want to clarify very important issues here. First of all, there must not be any thinking that there's no political will to finalize the status of community health workers. Actually, from where I'm sitting, it's a game changer in primary health care, not only in our country, around the whole world. Some years back, the World Health Organization developed a resolution about this, because ordinarily community health workers are people who are brought along mostly by NGOs all over the world to come and help healthcare systems, because they do a lot of primary health care prevention and in contact with communities. That is one human resources that is needed more on the African continent than all the other continents, but Africa needs it even more because of the nature of the disease, the infectious disease and all that. Now, the World Health Organization passed a resolution that they must be absorbed as part of the general workforce, so that they no longer come under NGO. They sit on the organogram of governments all over the world. And when you talk about the workforce, you count them. Remember, in the 6 building blocks of a healthcare system as defined by the World Organization, the workforce is one of the 6. And they wanted that workforce, which we call human resources, to include community health workers. The problem here are resources. And in case of South Africa, you are aware that, as they've already told you, any person we hire, you have got to ask for permission from Treasury. And at the moment, there are a lot of people which, from Treasury and DBSA, there are a lot of people who we are not able to hire. But now we are keeping community health workers on PESEL. The second thing I want to bring to your attention is that perhaps unlike other countries who might try to resolve this issue, our weakness in South Africa is the manner in which the present community health workers came about. I believe there are about 45,000, if I'm not mistaken, at the present moment. We developed a curriculum, because if we're going to be hiring them to be part of government, there must be qualification criteria. But also, if you are going to get into somebody's house and start inquiring about their health and pick up things, problems that you can see there, like TB, diabetes, how people behave, you need some form of education. You can't just be an ordinary person who just have got empathy for the sick. You need some form of training. So we developed that curriculum and said people must at least have matric. Now, when the process of seeing who is who was undertaken, we found that in the case of South Africa, quite a number of community workers came through volunteerism during that era when HIV/AIDS was a problem. There was no ARVs, people were dying. Somebody just wakes up and get into the neighbor's house, find the neighbor lying on the bed, perhaps even with children, and start helping them, clean them, feed them, wash them, and all that. That's how many people came in this. And so the government noticed them and continued working with them. So the belief was that we can't just wake up and say, you don't have matric, you can't go for training, or you have not been trained, we send you away. It will look very immoral. So what we did, we discussed with provinces that they must look into their organograms, find areas where they can come in. Like some of them can do the work as cleaners, some of them where food services have been insourced, they can go and work there. Others can become security, depending on their level and their skill. And that is the process where we are waiting for provinces to do, so that they absorb them there. And those who are left are the ones who will qualify according to the new criteria. So we still have a lot of work in this area. The issue of alcohol bill, I'll be very happy, Honorable Member Mtubat, to bring it back, because it's one of the bills that one has been struggling to let it go through, but we've been stopped by other interests, like those who are interested in the economic clusters. They feel like the economy will suffer, etc. But this issue of alcohol control in our country is very urgent, should have been done by yesterday. And I agree with you, we'll look at the possibility of bringing the bill back. Thank you very much. I'll continue over then to Dr. Tembekwa.
Thank you very much, Minister. I would request Dr. Mahlati, DDG for Human Resources for Health, to comment on acting positions. Dr. Mahlati.
Good evening, Honorable Minister and Honorable members, Minister, Deputy Minister. There is a bit of a problem with my camera. It seems not to be working. I've been trying it. I'm hoping that Honorable
But
Chair,
we can see you. What's wrong with your camera? We can see you very well.
Oh, it normally shows on my side, but it's not. Thank you. Thank you very much for the confirmation. In terms of the acting position, this is a long-standing problem which has got several, factors to it. The first one I would raise is a matter that we're addressing with the National Human Resource Committee around the issue of delegations. Delegations for appointment for HR, and usually there is also, the issue of finance delegations, around those. And basically, part of the problem also is the impact of the non-filling of posts, which has come with the budget constraints, that have been imposed on all these sectors. But going forward, one of the things that we're doing is that we actually just finalized consultations on a national hospital strategy that addresses quite a number of issues around there, including issues that would relate to clinical governance, issues of HR delegations with accountability, and also trying to find a way of the replacements of posts. When the austerity measures were brought on more than a year ago, there was a condition there that said the frontline, especially clinical, workers would not be affected. However, as time went on with the constraints on budgets it's been difficult for the provinces to really employ new people, which has then led to the acting positions because they cannot be filled. Some of the provinces have, because of the drastic measures, have ended up, basically, we're closing off posts once they are vacated, either through retirement or through death in certain cases. So those are the major challenges around it. But what we've done at a national level has been to really appeal to MECs and HODs to make sure that appropriate delegations are actually provided so that there could also be a mechanism of closing and reducing those positions that are acting. Thank you. Thank you, Chair. Thank you, Minister. Thank you, DG.
Thanks, Dr. Mahlatsi. Then there was a question on the staff dissatisfaction at entities level. Maybe the minister will help me here. It's a difficult one because the staff in entities, they fall under the entities have got the boards, which are the accounting authorities for the entities. And the function really of the minister is to set the regulations, appoint the board, and appoint the CEO at the recommendation of the board. But otherwise, they are separate from the staff of the department. But if there are issues that do come to our attention, we do take it back to the board of that particular entity just to deal with the matter. But maybe my minister will come in on this one as well. And then on the AG, I think we've dealt with the issue of the financial statements and the capacity that we've built internally in terms of appointing a number of senior internal auditors to improve on the preparation of financial statements, audit action plans, record management, and all the other issues that are always coming up as the repeat audit findings. I'll then request my minister to take over. Thank you.
Yeah, thank you very much, DG. The issue of boards, as DG is saying, is a little bit tricky because, as he has said, they do have their own boards, but they don't stop complaining to us. And of course, we engage the chairperson of the board and the CEO to find out what the issues are. And quite often, it's difficult to resolve them because the workers simply don't get satisfied, regardless of whatever conclusion you arrive at. And then we encourage them to follow the normal public service rules, like going to the Public Service Commission or CCMA or whatever, but we do try to intervene. Others, Honorable Member Dr. Tembekwayo, the complaints are very vague, and it becomes very difficult. You find that you are chasing geese, For instance, 2 days ago, I received a letter from the Office of the Health Umbad. They are complaining about 3 individuals there who they say are oppressing them and all that. And I've asked for a meeting with the Health Umbad. I don't think he has received my letter already because it's only, as I'm saying, 2 days ago. I said they must arrange a meeting with it. But the problem with the complaint which I received, they are refusing to put their names. Usually people claim that we don't want to be victimized, but they make you sit in the dark because you want the clarity about the nature of the complaint. And in order to even respond to them and tell them that I'm dealing with the matter, they just refuse and they say investigate. And I can assure you, I've investigated many of these cases when I was in Home Affairs, where people refuse to come out. You usually find nothing and you don't know how to go. Not that anonymous things are not investigated, but they must make some bit of sense. You can't just go into the dark and somebody just said, there's a problem there, investigate. I'm not satisfied, investigate. So that's why our difficulty is. But if people are specific and they show themselves, we do try to intervene within the realms of the law. Thank you very much. I will move over to Dr. Dr. Domo is calling it like do in the kingdom, he said, Sen, is sin. I'll go over to Honorable Sinda. Can you start, DG, about HIV/AIDS and STIs?
Thank you very much, Minister, and thanks to the chair and members. Reverend Morewane, you will deal with the first one, and then Professor Chris will come with the HPRS. Reverend Morewane?
No, thank you very much, DG, but thanks very much again to the leadership, the Minister, Honorable Deputy Minister, the Chair, and the other members of the committee. Maybe this matter, I need to start at the reasons why we had to come up with the youth zones. We came up with the youth zones as a response to complaints that the youth or young people had raised, so that it's best understood. So the purpose was to make sure that we improve access to services for these young people, so that they don't go through the main door of the clinic where everybody else is going, so that they're able to be seen in the privacy of their spaces, treated by either young professional or somebody who's really, easy to work with, particularly with young people. We're responding, for an example, through the slogan, when they were doing to the slogan of Zikhala Kanjani. We know in the past it used to be called the She Conquers. So we're therefore responding to that. Now here, whether we've got an impact or not, I must just say, in terms of the way we work, impact can obviously be seen after some time. But here are the issues that we're dealing with. We do know that young people get started on treatment for HIV and AIDS, with 15 to 24% of the young people, or 50 to 24-year-old, get lost from ART immediately after ART initiation, 3 months after initiation. So we do get them on treatment, but they immediately slip away. So we are aware now currently that around 32% of people that are living with HIV and AIDS among this age group of 50 to 24 years old, they know their status, they know they've got ART, but they are not on treatment. Either they've not yet started or they initiated and they opted out. So what we're doing to address both the STI, teenage pregnancy, and HIV and AIDS, we're working together with what we call adolescent boys and young men, adolescent girls and young women, to make sure that we intensify our education to them. We're also leveraging the integrated school health program so that we can offer HIV testing services in schools. We're working together with the Department of Social Development, together with a group or an NGO that's called DREAMS, which DREAMS is an acronym standing for Determined, Resilient, Empowered, AIDS-Free, Mentored, and Safe Young People. And all these are the efforts to try to reach out to young people. But we are hopeful that the more they respond and come to facilities, the more they're able to, we're able to see the impact. But as you know, teenage pregnancies is more complex because it's a societal matter that would want to perhaps appeal to the whole of society to respond in order to join hands with the Department of Health to assist young people, so that they may then refrain or abstain from sex while they're still at school, use condoms, and do all kinds of prevention so that we can avoid the teenage pregnancies. There's also been a campaign, very, very strong campaign, to make sure that we clamp down on illegal abortions, because this one also serves as incentive for young people to fall pregnant, knowing that they can go to anybody else so that they can terminate the pregnancy. Again, in this regard, we do have what we call social behavioral change communication, as I said about TB. It's a program that's entrenched in our work together with SANAC to make sure that we encourage young people to be adherent. We also lastly have we've established what we call youth care clubs, so that again we can draw young people to that. And all these efforts are meant to perhaps over time to see the impact in the reduction of STIs, reduction in the teenage pregnancies, and reduction in the incidence of HIV and AIDS among young people. Over to you, DG, but thank you very much.
Thanks very much, Rev. Over to you, Professor Chris.
Yeah, thank you very much, DG. So the good news on the HPRS is that after quite a lot of regression during COVID and in the anticipation of the NHI, people had got old equipment and not been maintaining the versions of the HPRS. But now we have got teams that are going to each province. There are action plans being developed in each province now to renew the versions, so make sure that everybody's using the latest version. There are a number of facilities who no longer have their equipment for whatever reason. Some of them have got old and are no longer usable. So those are that equipment, to the extent that we have budget between us and the provinces, is being replaced. So there are about 52 primary healthcare facilities at the moment that don't have the necessary hardware to be able to run the HPRS. But it is installed in 3,145 primary healthcare facilities, and there's enough resources in our budget to extend HPRS into 30 more hospitals by October 2025. So the Western Cape province is not participating in HPRS because they installed the system a long time ago, 19 years ago. But their data system is synchronized now through the National Patient Registry, which is created by the HPRS. So we are moving very quickly to a point where the entire country, particularly the entire public service for the time being, but as I indicated, where we are working in the CUPS, it will extend also into private primary healthcare providers, will all be connected on the HPRS and have the functionality of the HPRS. Thanks very much, DG.
Thank you, Professor Crisp. I don't know, I don't see the minister. If Deputy Minister, I can go on to the next question from Dr. Letlhapy.
Yeah, you can proceed, but the minister, I'm also just on the road, but I'm on live, but I'm sure you can.
I'm still here, DG.
Oh, my apologies, Minister.
But you can continue with Dr. Letlhapy, yes.
Okay, thank you very much. Professor Crisp, can you deal with the two matters there? Is the contracting arrangements in terms of the CUPS? I don't know if you've seen the US COVID vaccine report. I have not seen it, but yeah. I'll allow you to do that, and then I will come in thereafter. Thank you.
Okay, thank you very much, DG. So to Honorable Letlhapy, so we are implementing what we call proof of concepts. So the contracting units for primary healthcare will be the vehicle for the distribution of the primary healthcare funding through capitation. We've never done this before, certainly not on a large scale. So we are testing the mechanisms for distributing and paying in the primary healthcare space using just these 9 sites. Each of the sites is quite small, one in each province. Some provinces have decided to already expand and start preparing other sites. There's no payments that is taking place, and there's no change in the actual systems yet. What is happening is that we are identifying all the private facilities. We are updating all the HPRS into all primary healthcare providers, as I've indicated. We are using the new modules, implementing the electronic medical record, making sure that the private providers, particularly GPs at this stage, are integrated with the public health facilities into the delivery of primary healthcare. And we have developed, as was reported in our annual performance for last year, the capitation framework, so that we at least have the model. We've also got a program that's going on at the moment to quantify the costing, that is, or the actual expenses of what is being spent in primary healthcare. There are 2 parts to that project. One part is the public sector, where we need to disaggregate the data and the way it is collected in the BAS system of the public service, but also then to collect data on what is being spent in the private healthcare system in primary healthcare. And it's not as simple as going to medical schemes. It includes out-of-pocket payments and a whole range of other things as well. So this year and into the first half of next year, that is what we are doing, getting 9 sites where we understand them well. Each of these sites is very different. Some have very few private providers, others have very many private providers, some are very rural, others are urban. And we are trying to understand the implications for the rollout and the way in which the rollout modules will be effective once we start to implement NHI into the future. So at the moment, it's not a question of value for money yet. There's no money transferred into any fund. The NHI as an entity doesn't exist and doesn't have a fund yet, but this is the preparatory work that we are doing. The DG asked me to address the question of the COVID vaccine. I'm familiar with what's going on here, and I've seen the social media responses regarding this alleged Supreme Court ruling. The date of that is the 22nd of October 2022. So this was already some time ago. The ruling was not from the Supreme Court, the federal Supreme Court in the United States. It's from New York. And it was not around the vaccine per se, but around the vaccine mandates that had been implemented in New York State. So it's a little bit of a more complicated ruling, and I don't think this is really the place to go into it. But Honorable Letlapi asked about when there should be an update on what we learned from COVID. We did have quite a number of debriefings shortly after COVID, particularly on the vaccination program, but also on other lessons learned. But I'm not aware of any imminent plans for further updates on what we learned from COVID. Thanks, DG.
Thank you very much, Professor Crisp. Let me talk on outsourcing of oncology services in Gauteng, which, by the way, is not only limited to Gauteng. We do have, even in KZN, where they've outsourced some oncology services, and also in the Northern Cape. And I must say, these are really provincial decisions to deal with the backlogs in their own provinces. But one of the big issues that we have in Gauteng is that we've got a lot of cases in terms of the backlogs, and they then went out to try and see if they can get assistance from the private sector. The major issue why we have so many backlogs has been that we do have a number of machines at Steve Biko, but that are not optimally used because of an issue of the shortage of the radiation therapies, which is a matter that we're trying to address to see if they can be able to utilize those machines optimally. At Steve Biko, also at Charlotte Maxeke, they're also going to be putting the other lean accelerators at Chris Hani Baragwanath Hospital, and also at Dr. George Mkari Hospital. So it is a provincial decision, and they've gone on the procurement, but it's not really limited to Gauteng. On the Charlotte Maxeke and the fire, there are actually weekly meetings which I sometimes join on Wednesday mornings that are chaired by the DG for Gauteng, Edward, with the implementing agent that they have contracted, which is the Development Bank of South Africa, and then with the different people that they are working with in the provincial treasury. The work is not moving as fast as we want it to move because they've also hit a snag in terms of the finances. But I must say that there has been quite progress in terms of the work. For example, they've restored all the parkings, more than 400 parkings that had issues, and we've opened also with the assistance of the funders, like from the Solidarity Fund and also from the Gift of the Givers. Those buildings have been finalized and have been commissioned. Now the bigger work of restoring the other wards in the area is what is currently ongoing, hence the weekly meetings, which I always get invitation to, though I'm unable to attend them all the time. So we're following up on the matter, and we believe that the Development Bank of South Africa is competent enough, and we are happy that they finally agreed to work with the Development Bank of South Africa. Then on the issue of Rahima Moosa, the Ombuds findings, we are following up on those findings, and some have actually been implemented. But the bigger issue that we have with Rahima Moosa, even though we have put it's part of the projects that are under the Health Facility Revitalization Grant, is that the problems are bigger than the ICs, because the whole hospital, they have a problem with the infrastructure underneath in terms of the water pipes, because it's quite an old hospital. It used to be called Coronation Hospital. So the province is trying to mend and deal with the matters. But on the matter of the HR that was addressed, the CO appointed, the previous CO was actually moved from the hospital, and there's quite a lot of work that is being done onto that. At Helen Joseph, yes, we agree there was quite a huge negative media coverage, which the minister had also to address, and we brought in the Office of the Health Standard Compliance, and we're waiting for the report from them because they've done a recent inspection just to see what are the urgent issues that we are able to deal with. But there are quick wins that we've been able to put in place, like work on the issues of replacing beds and get the modern beds, which we're doing as a countrywide project. And we are actually going to have on the 31st a formal report back from the HODs on that matter, because I think it's not only the Helen Joseph, there are other hospitals there that we really need to address just the low-lying fruits in terms of the aesthetics of the hospital and staff attitudes and the other areas. The issue of the patient load from the foreigners, it's really a very difficult issue that we are dealing with. And we agree that most of the hospitals around Gauteng, including Rahima Musa, Helen Joseph, Hillbrow Hospital, hospitals in Limpopo, they have a lot of especially obstetric patients that come and deliver. And what made things even more difficult for us is that in the previous administration, we were actually hit with a court order that was led by Section 27, where we are actually obliged as the department to offer health services to all children under 5, irrespective of their origin, and also to the pregnant women that come into the facilities. So we are starting a program now of actually doing the proper quantification of these patients that come through. Very difficult to budget for because they are not in the population register, most of them. But the even more difficult is that most of them present very late. Some of them, they come fully dilated. And sometimes we get bad outcomes in terms of the pregnancy outcomes. So it's the issues that we are looking closer to see if we can be able to have a proper approach to it, obviously guided by our political leaders. I think the minister has responded on the issue of the CEO appointment, that the matter is with the Public Service Commission. Unfortunately, as a department, our hands are tied in terms of the law, but we'll wait for the outcomes of the Public Service Commission as the relevant Chapter 9 institution that is currently investigating the matter. I don't know, Minister, if the Minister wants to come in under Dr. Letape's questions.
I think DG have answered them very well. Thank you.
Yeah, can I just
Yes.
add something?
Thanks, Commissioner.
Yeah, just a quick one on the Charlotte, to say that in fact, as late as late last year, despite the slow progress which the DG is mentioning, but in terms of clinical functionality, the hospital was already at 90% of recovery of functionality, because quite a lot of the work which still needs to be done is in terms of many of the wards not being compliant in terms of fire security. So, but in terms of commissioning and making sure that the clinical services are functional, the hospital was already at 90%. So once more work is done, hopefully, which can be done quicker, then there will be a lot more progress. Lastly, just to say that the matter which Honorable Mtiwatsi raised, it also raised with me in the Parliament about Guguletu. It so happened that I did visit that area early this year, and there is an undertaking from the province, which I'm sure from our team we just need to follow up. They do accept that that clinic actually has to be relocated. I think they already had in their plans, because it's quite a congested area, very inconvenient, and deals with huge volumes of patients. So I think it's a matter which our primary health care team, together with infrastructure, just need to follow up with the province. Thanks, DG.
Thanks, Mr. Minister.
DG, yeah, I said I've got nothing to add on Dr. Letlapi. I think I made a mistake. I think I made a mistake. Can you allow me to speak, Chair, without the video? Because now I'm on the road, I'm starting to experience problems. If you can hear me, can I go on?
Yes, you can go on. Thank you.
Yeah. On the issue of vaccines, I'm sure Dr. Letlapi, you are aware about the speed with which things happened because of the nature of COVID. But since that time, an international body has been put together called DG, help me, I always forget this abbreviation. It's Intergovernmental Negotiating Body.
Yes, INB. Thanks, Minister.
Yes, Intergovernmental Negotiating Body has been formed in Geneva under the auspices of the World Health Organization. And fortunately, our former DG, the former DG of Health in the Republic of South Africa, is chairing that international body where they are negotiating about what lessons have we learned during COVID and when other pandemics come, what do we do? This includes the issues of vaccines, who is holding vaccines as it was done, under what conditions are the resources that are there shared by countries, even the rich and the poor, under what conditions do we sort of manufacture vaccines and all that. It was believed that when that body has finished negotiating, if there's agreement, ministers of health are going to be called to Geneva for a special meeting where they'll endorse them. This, if it happens, it will be historic because it will be happening only for the second time in the more than 70 years history of the well, 76 years, yes. In the more than 76 years history of the World Health Organization, it will be happening only for the second time for ministers to call to Geneva twice a year. I'm saying twice a year because every May there is World Health Assembly. All ministers of health go to Geneva. So if for the second time, it will be a second time in a year and only a second time in history to adopt this. So it's a very, very historic thing, but it looks like by now, because we received no notices, by now they've not yet reached agreement. And I think as in the nature of international agreements, they are meeting some problems, but they are still continuing to negotiate. Thank you very much.
Thank you, Minister. With your permission, we'll then move on to the questions from the chair, Dinangwe. I think I'll deal with the first question, and then Dr. Tulare must be ready for the G20 program of health, as we'll be taking over the chairmanship of the G20. I think it's correct, Honorable Chair. What the Ombuds is saying is that some of his findings in terms of what happens is some of the things that end up in medical legal. Hence, we always say that the problem of clinical governance and proper quality patient care, if that can be sorted out, it wouldn't be actually be dealing with the end matters or the consequences when it comes to the litigation. Hence, Dr. Mahlati, when he spoke earlier on, he spoke about the issues around the issues around the hospital strategy, on what needs to be done in terms of the clinical protocols, the mortality audits, and actually ensuring that you also look at the adverse events, the near misses, and then we are able to deal and prevent those moving on forward. It is also important that as a department, we have three very important committees, as the chairperson mentioned, that actually also just advise the minister. One of them is called the National Committee on Confidential Inquiries into Maternal Deaths, that actually look at some of the causes of the maternal deaths, and some of those causes they are actually put in as patient-related or as healthcare worker-related, where we're looking at the issues of the numbers, the skills, the availability, and those are the matters that we always deal with when we deal with these committees, who give us actually triennial report. The other one looks at the perinatal mortality, and the other one looked at the mortality in children under 5, which is called COMIC, which is a Committee on Morbidity and Mortality in Children. So all these committees coming together, if really we actually ensure that in facilities, we have senior experienced doctors who are able to actually oversee the younger doctors and also follow the protocols in managing the patients, we could be able to prevent quite a lot of these mishaps, some of them which then obviously end up being investigated by the health ombuds or end up being what were being litigated against as the department. So that work is ongoing and we are pushing it to ensure that in our facilities this is properly done. In addition to that, we have put in, as the chair is aware, which we are now also strengthening, what we call district clinical specialist teams, really at the primary healthcare level, where we look at the key issues that affect mothers and children, where we've got different specialties at a district level to provide guidance, clinical governance to district hospitals and also primary healthcare facilities, and do outreach work and do the training to ensure that we do actually prevent or actually deal with the preventable areas that lead to morbidity and the mortality. On that note, then, may I request Dr. Aquina Tulare to talk on our preparations for the G20 as a country and the program for the G20. Thank you, Dr. Tulare.
Thank you, DG. Good evening, Honorable Chair of the Portfolio Committee and members of the Portfolio Committee. Good evening, Honorable Minister and Deputy Minister and colleagues. South Africa is going to be assuming the presidency of G20 in 2024. And as the presidency of the G20, we have adopted an overarching theme as a country that has been approved by Cabinet, that of solidarity, equality, and sustainable development. And solidarity signifying a unified effort and mutual support amongst member states of G20, equality in terms of fair treatment, opportunities, and advancement for all individuals and nations, irrespective of their economic status, gender, and geographic location, and sustainable development, which integrates economic growth, social inclusion, environmental protection, ensuring long-term health and stability of all people on the planet. As South Africa, we have also based our identification of priorities on the African Union health priorities of a strengthened public health institutions, public health workforce strengthening, expanded manufacturing of vaccines, diagnostics, and therapeutics through local and regional manufacturing, increased domestic resources for health security, and action-oriented partnerships. Based on this, we as health are part of the 15 sectoral working groups that are led by our Sherpa, which is the DG of DERCO. There is another track, which is the financial track that is led by Treasury. So as a health working group in South Africa, we are working through DERCO to finalize our priorities. Preliminarily, we have identified the 5 priorities that are underpinned by accelerating universal health coverage through equity, solidarity, and innovation. So our priorities are as follows: strengthening of primary health care as a pathway towards universal health coverage, pandemic prevention, preparedness, and response as the second pillar of our priorities. The third one is on human resources for health strengthening. The fourth one is on stemming the tide of non-communicable diseases. And the fifth one is on science-based innovation. These priorities are still being fine-tuned, and we have to submit them to an interdepartmental committee that is chaired by the DG of DERCO, and that reports to the interministerial committee that has been established to coordinate the activities of G20. So our legacy is going to be derived out of this, but we will still have to streamline and make sure that we do not have too many priorities. So for now, The 5 areas have been prioritized and we are still streamlining them, and work is continuing. What will happen is that after the upcoming G20 summit of heads of state, which is taking place in November, we'll be required to then submit our issue notes through DECO and share them with the other countries that are members of G20. And only after that can we be completely certain that our priorities are aligned and that other countries are also supportive of these priorities. I thank you, Honorable Chair.
Thank you,
DG,
Dr. Tulare. Minister?
yeah, the last question from Dr. Dlomo is about the issue of food. Who is responsible for what? You know? Am I correct?
Oh, yes, my apologies. Yes, I missed that.
Yeah, I would like to answer it.
Oh, thank you, Minister.
Yes, because I'm sure Dr. Dlomo is asking it because of the events that are taking place in the country that are very problematic and very painful for all of us. When it comes to the issue of food, many departments are involved. Each one of them have got their own important role. So, like you are aware that the Act on Food and Cosmetics and Medicine Regulation is in the Department of Health, but Department of Agriculture has also got some very serious regulatory authorities, as is Department of Environment, as are the various municipalities. They've got sections that deal with that, but we also have the National Consumer Commission, which also deals with that. So what happened is that 2 days ago, we brought all those groups together. We brought them together to sit in one roof because many of them have already done some job on these mishaps that are happening, especially in Soweto with school kids. We have already said and got reports, and we put together a program of action, and we are going to be briefing the nation via a media statement very soon, and next week in a press conference, because we have put together a plan of what we do about the present situation. And I'm not in a position to report at the moment fully exactly, but I just want you to know there is a course of action by all those involved, being the National Consumer Commission, the Department of Health, the Department of Agriculture, even police, because there is some bit of irregularity or criminality reported. Even them have thrown their weight in. The city of Johannesburg is also involved in there, and the environmental section of the Department of Health, the area where the unit which we call health inspectors. So all those things have come together, and we are dealing with the matter, and will very soon be reporting to yourself and the nation what actually we found out and what we are doing. Thank you very much.
Okay. Okay, thank you very much, Minister, and your team. Before we get to signing off, let me just raise some of the things that, and one announcement to make, that the Office of the Health Ombudsman is actually continuously requesting you to improve on their staffing, right? There's to bring in from the team, from the issue that to work with her. So even you can see these from the entities. So we will look to work on it. are from outside South Africa. For how long?
Chairperson, but I don't think we can hear you clearly. Maybe I'm the only one who can't hear you.
Yes, Chairperson, you're breaking up. We can't hear a thing.
Same here.
Maybe he can just switch off the video. It's affecting his speech. And now he's gone.
Oh, yeah. Oh, okay.
Dr. Domayakushaya network.
Let me.
Still can't hear.
Okay. Can I use the other gadget now? I want. Is it better now?
Yes, Chair, but
Yes.
start from the beginning. We didn't hear anything.
Okay. Minister, there are certain things that have come up from one, if I have to start from all over, the Office of the Health Ombud, they are complaining continuously. They have seconded staff from Office of the Health and Compliance. Please assist them to finish off with that part. Two, I'm glad the DG came up on the issue of Gugulethu Clinic because Honorable Mutubasi did raise this matter with us, and we will then appreciate your working on that. The issue raised by Honorable Dr. Tembekwayo was with relation to SAPRA employees. We promised to work with the leadership there on those complaints that are sitting with her, and then we try and work on that part. Honorable Minister, we would really request you to do a bit more on the issues of foreign nationals. We have just visited Northwest. Half of the patients in the maternity wards of those hospitals are coming in from outside South Africa. Now, not just one day, every day. Now, you would actually be able to say, when you allocate them a budget and you allocate a budget based on the population, how do they on a daily basis take that? So I think, Minister, you can't postpone this for too long in terms of an interministerial committee to look into that part and really be able to indicate to us what is the progress on that. Lastly, to the members, let me then say there's been a notice given to me by the Office of the Minister that he is out of the country on the leaving on the 27th. So, honorable members, we have moved the meeting that was supposed to be on the 30th of this month to 27th on to 23rd. So that meeting, so that we can get the benefit of both the minister and deputy minister in the country, will be gone out of the country on the 27th. So we will not have our meeting, the next portfolio committee meeting on the 30th, but we will have it on the 23rd. It will be a virtual meeting to complete our preparations with the minister, with the department on the tobacco bill before we can take it as our own product going forward. I thought I should just announce that to the members that we will meet virtually next Wednesday. We will want the minister and his whole team to come in and finalize our preparedness in understanding the tobacco bill as a portfolio committee of health. Thank you very much. If we would then thank the department, thank the minister, deputy minister, all our members for logging in. I do notice, Ms. Machalamba, that Honorable Reverend Kwabaza did log in halfway in the meeting. If you can just notice his presence in the meeting. If there is no other issue from any other member on the department, we can then bring our meeting to a close.
Thank you, Chair.
Thank you, Chair.
Thank you. Have a good
Thank you,
evening.
Chair. Okay.
Bye.
Thank you.
Thank you.
Happy clubbing.
Have a good night.
Thank you. Thank you, Chair.
Bye.
Recording stopped.